All right. Well, appreciate everybody joining today. So I'm going to look at an Alzheimer's disease phase 2 trial. Um, let me move forward. I'm going to show you a clip from a movie, which is going to make a point for me from the Amadeus movie. I'm going to show you the design. I'm going to show you its simulation and facts. And the nice thing about this trial is the results of the trial have been published. And more than any other trial, not just the results of the trial, but the results of every interim analysis were published. So I'll show you the trial and facts, and then I'll show you a movie of the real trial from this. But before I show you a movie of the real trial, I'm going to show you a movie. This is a scene, and there's a point to this. This is the movie Amadeus. It's about Mozart. And this is Mozart's wife has brought music to Salieri, Antonio Salieri, another composer, and he's looking at this music. So I will show you this scene.
These are originals?
Mm-hmm.
Astounding. It was beyond belief. These were first and only drafts of music. But they showed no corrections of any kind. Not one. He had simply written down music already finished in his head. Page after page of it, as if he were just taking dictation. And music, finished as no music is ever finished. Displace one note, and there would be diminishment. Displace one phrase, and the structure would fall. It was clear to me that sound I had heard in the Archbishop's palace had been no accident. Here again was the very voice of God. I was staring through the cage of those meticulous ink strokes at an absolute beauty.
Okay, so what was the point of that? Several points to that. The point of that is I'm going to show you this trial, and you're going to see the final version of the trial. But it's the exact opposite of what I just showed you, where this is not the most important part of this message is this is not something that this design came out and was dictated in somebody's head or dictated from God as the design, and then we simulate that one design and it's good to go. This is the exact opposite. It was 6 months of checking every value, every cutoff. Is response adaptive randomization beneficial here? What's the likelihood of getting the right dose? What's the go, no go criteria? Do we change it by interim? So all of that was the exact opposite of this. These designs are not, ooh, how about this design with a threshold of 0.95 and we do RAR and we do interims at these 4 points? and boom, it was dictated from God, designed. The important part of all of this is simulating it. And as you referred to it, if you change any one note, there's diminishment. The structure doesn't hold up. If you change parts of this design, it changes the operating characteristics. So this has been simulated, and that's the part of facts that's actually the huge value here, is being able to iterate the design. When I was going back to this design, I found 17 directories of simulation results, which were the iteration of all of the parts of this. So I am not Mozart. I cannot dictate designs from God, and the value of facts is it provides that mirror to see, is this good or not? So let me show you what the design is. Um, the design, this is the final design after months of iteration. There are 5 arms in the trial. There's, I'm sorry, 6 arms. There's a placebo and 5 different treatment arms. There's 2 different dosing schedules. There's once a month dosing of the equivalent of 5 milligrams or 10 milligrams. And then there are 3 dosing that are bi-monthly, given twice a month in this scenario. So the 5 arms in this are being explored. The primary endpoint in the trial is, I'm going to talk about 12-month change from baseline. An interesting part of this, and it becomes a really interesting part of the story, is that all patients are followed to 18 months. The adaptive design, my simulation is going to be triggered by 12 months, but patients are always followed for 18 months. The primary endpoint is ADCOMS. You may not have heard of this in Alzheimer's. It was work done to try to identify an endpoint that was more sensitive in early disease. It's a combination of parts of MMSE, ADAS-Cog, and CDR sum of boxes. So if you have those 3 endpoints, you can construct the ADCOMS endpoint. And that's the primary endpoint in this phase 2 trial. Its scale is really small. So 0.03 on the scale, maybe they could have multiplied this by 100 and people would have thought it was a better endpoint. But 0.03 was originally identified as clinically significantly important as a 25% slowing of disease. So the expected decline in a year is 0.12. Going bigger is bad, is progression of disease. You're doing worse if your value is getting bigger. So the trial design, and again, if you looked at this, if Salieri looked at this design and said, wow, this was dictated from God and all the thresholds and all the values, it was not that at all. It was exactly the opposite. All of this was simulated from the sample size, the frequency, the adaptations, the thresholds within this. The maximum sample size of the trial is 800 patients. Very large phase 2 trial. The interim analyses, you can see there are 17 analyses defined with this. Interims are the first 12, really, that can affect sample size. The first interim at 196 patients. What happens there is randomization is updated. You cannot hit superiority. You could stop for futility and stop enrolling at that time point. And then 250, randomization is updated. You cannot stop for superiority, futility, yes, and so on. The first time at which the analysis at 350 patients enrolled, randomized in the trial, update randomization, it could hit a superiority threshold, which would stop randomization, but not stop exposure. Super superiority, and I'll show you what that criterion is. And it's a probability that we have at least that 0.03 on ADCOMS at 12 months. So the expected 25% slowing or greater. That is a drug development threshold that they would accelerate phase 3 planning. They would start phase 3. We hit a go, no go. Meanwhile, in phase 2, the exposure would continue on all the patients, but they wouldn't enroll more and they would accelerate phase 3. They could stop for futility, which would also mean that you stop enrolling patients at that time point. The interims go up to when 800 are enrolled, there's no more randomization, so no more updating of that. But we continue with the drug development. Does this look like we want to go forward with at least a 25% slowing? Or do we want to plan to stop development with futility? Interims happen periodically every 3 months because it goes through 12 months. And then once the 12-month final is done, all patients have reached 12 months, another analysis happens when all patients are at 18 months. So that's the trial design. That was the final iteration that came from this. The randomization was a burn-in period where 4 would be a relative of 4 to 14. Would be given to placebo, and then 2 to each of the 5 arms, the 2 monthly schedules and the 3 bi-monthly schedules. So that first 196 would be randomized 56 to 28 to 28 to 28 to 28 to 28, and then an interim would take place and adaptive randomization starts. The control was a little bit weird, and it's not interesting to go into that. Essentially, it's 2/7, so the same ratio of control stays during the trial, but the randomization to the 5 arms is varied according to the probability that the arm is the ED90 arm, the lowest dose that achieves at least 90% of the efficacy of the maximal dose. This is information weighting of that. So this weights it by the variance of the estimate of the 12-month response by its sample size. And so this gives a relative, smaller sample sizes are going to be more likely to be enrolled to because you get more information from that dose. So that's the quantity that's dictating the RAR in the trial for the active arms. The dose response model is a 2-dimensional dose response model because we have frequency of dosing and magnitude of dosing. The dose response model analyzes placebo separately as its own arm. And then there's borrowing in both dimensions, dose and frequency. And this is done with a 2-dimensional normal dynamic linear model, Gaussian process within that. So each dose could borrow from doses with the same frequency, but also borrow from doses of different magnitude. Okay. Oops, let me get out of that. Something I didn't say, I want to go back to. The ED90, we think of that as usually in a monotonic dose, amount of dose. In their setting, they specify the order of the doses. So they think of the simplest dose as 5 milligrams once a month. That would be the easiest, lowest dose for them in the ED90. So that's considered the smallest dose. 10 milligrams monthly, the second smallest, then third, fourth, fifth. So this effective dose 90, this is the ordering of the doses in terms of simplest to most complex or most drug. Okay. So
Scott, we have a question about the recruitment rate. So will you maybe just pay attention or talk about the duration and accrual as you go through these?
Yeah, I on here, I'm going to show you the timing of when they actually happen. So the interesting thing is we know what that is in the setting. And so I'll come back to that. I didn't want you to see that yet, but I'll say something about accrual, sure. An important part of the story, actually. So here are the simulations of the trial, but let's go to the study in facts, and I'll try to show things I just saw. Within facts, I'm doing adaptive features. Longitudinal modeling, as that question just asked, is a critical part of this. We're driving this off the 12-month change from baseline, 52-week value, and we're going to be making RAR decisions before a single patient gets to 12 months. And so the longitudinal model is going to be important here, and accrual rate's going to be important here. Patients, I get values every 3 months. Are the values. Maximum sample size of 800, lower is better, higher is worse. Now, the treatment arms in this setting, I've used the two-dimensional treatment arm model in FACS. FACS allows you to specify the 2 dimensions of it, and the 2 dimensions are the dosing, 2.5, 5, 10. So I've just arbitrarily called that the column. So the column is dose, and then the row factor is frequency. So I've created that, which actually creates 4 by 2, 8 doses, but I don't want to use control at different doses or the 2.5 once a month. So I click the dose values in the factorial that I want to use in facts. Then I described to you that they actually, now from this, it's not clear if you're ever going to do minimally effective doses or ED doses. What's the order of the doses? And I described to you the 5 milligram once a month is 1. So I inputted these dose values 1 through 5. That's used in the effective dose 90. And by the way, I can look at the grid of doses, and I can see bi-monthly, I have placebo, I have 2.5, 5, and 10. And I don't have these doses, but I have once a month, 5 and 10. And notice it tells me what are the dose strengths. It's 0, 1, 2, 3, 4, 5. So I've set it up in this two-dimensional dose response model. I haven't said what to do with the 2 dimensions, but I've set up my arms to be in this 2 dimensions. I could do an independent dose response model, and FACS doesn't actually care that it's 2 dimensions, but I've created it that way. I am going to model it recognizing the 2 dimensions. All right. My design, my quantities of interest are all standard. I've specified 0.03 as my clinical significant difference on this endpoint at 12 months. I'm going to use the ED90. And so I've specified the quantile. That's actually the default value is 0.9. So I didn't have to change that. And I've created a quantity that I'm going to make adaptations on, which is what is the probability the dose is better than 0.03. This is the super superiority. What's the probability of at least a 25% slowing for a dose? And I'm going to look at the most likely ED90. That's going to trigger futility and superiority in my trial. Actually, quite simple criterion. So now I've told FACS I'm going to use that value for adaptation. My design, how am I going to analyze data at 12 months? I'm going to use the two-dimensional normal dynamic linear model. And in this, I've specified the prior on the initial dose. I've specified the prior on the tau parameter. This parameter is the one that, do I want to do borrowing differently in the magnitude of dose and the frequency? And I've specified by that being 1, it's the same tau. So we borrow in both north and south, east, west with the same tau. I could do that differently within the setting, but that was the smoothing that was decided within the two-dimensional normal dynamic linear model. And you can look at the adaptive design report, the protocol, the initial paper on this. This is the model that's used. A critical part of this is now the longitudinal model. This, not only in the design is this really important, it actually became more important in the actual data. And I'll describe that to you. So each arm is modeled separately. And each time point to final is modeled with a linear regression. We put a fairly strong prior on this. Notice the alpha and beta. Alpha is mean 0. In hindsight, given this is a progressive disease, I probably should have done something where alpha is expected to be positive over time, but this is reasonably flexible. But the beta has a pretty strong prior. Regression to the mean tends to be less than 1, and a standard deviation of 0.1 to that slope of beta of 0.8. The expected standard deviation in the 12-month response is expected within patient to be 0.15. So we put an estimate on this of 0.1 with 5 patients worth of weight on that value of 0.1. So smaller than the 0.15, but the same prior on all time points and doses. In hindsight, when I was doing this, I kind of wished I'd have done maybe a different value by arm. I'm sorry, by visit. But this was the same value within the trial. The allocation here is, as I described, you can see the 56, 28 on each of the arms. Fixed allocation after that to the control, 2 out of 7, 4 out of 14. And then information weighting on the probability each dose is the ED90 dose, is what is used as the randomization, the adaptive randomization for each of the updates. Now I have this where at 196 patients, I want RAR to kick in, but I don't want success to kick in, but I do want futility to kick in. So my interims are defined at 196 enrolled, 250, 300, 350, all the way up to 750 in the trial. I want interims to take place, and those are 12 interims that could take place. I want different rules at every interim. So when I go to my rules in the setting, I interim 1, 2, and 3. So if I go back to that, interims 1, 2, and 3 up through 300. It's automatically going to do RAR, by the way. So I've told it to do RAR. So at the first interim, it's going to do RAR. And then it's going to only do futility. It can't do success at the first interim, but it can do futility. If the probability that the highest likelihood ED90 dose is at least a 25% slowing is less than 5%. So the probability of a super superiority is less than 5%. It would stop for futility at the first interim, and the second and the third. Then at the fourth interim, I want success to kick in. So now, by the way, the rule changes for futility. It gets a little bit higher. It went from 5% to 7.5. And I could put a tab on here for every interim if I want the rule to change on each one. But initially, when simulating different thresholds at the first three and at the next one, we chose different values. We wanted to be a little bit harder at the first three because too many times it kind of triggered too easily when we didn't want it to. But then we wanted to be a little bit more aggressive as the trial went on to 7.5. If there's a 95% chance of super superiority in the trial, we want to trigger superiority, stop enrolling, and go to phase 3. That happens all the way up to the final evaluation at 12 months, which same thing, futility. Remember, these patients would be followed through 18 if this doesn't trigger, and 80% chance of super superiority. They want to go and run phase 3. If not, they keep looking and they look till everybody gets to 18 months, and they would repeat this criterion. But then they would unblind themselves and make a decision as to whether they want to go to phase 3 as traditional drug development would be done. So that was much less interesting to them at that time point, simulating that 18 months because they would be fully unblinded.
Before you move on, there's a question about the futility rule. You have like at interims at every interim analysis, you have a futility rule specified, but you also have follow-up patients after futility selected in interims. So what is the futility rule in this case? Is there an opportunity for final analysis success, or is that just so?
Yeah.
Yeah.
So good question. I did click that to see what the final value was to know in the counterfactual what would have happened had it gone to the end. But in the trial, I believe they may have even taken patients off the drug and they would not have had full exposure on futility. But I wanted to simulate that full exposure, but I think in the real trial they would have pulled people off drug and stopped it. Somebody asked about accrual rate. I put 4.27 in here. That was within the bounds of what we simulated. We largely in the trial before it started, we simulated 3 rates. I put in the actual trial, the closest thing I could to the real value of what it was. So 4.27 per week, just under 20 a month, which is an enrollment here of about full accrual of about 4 years. But I'll show you actually how long the trial took, and there was an interesting aspect to accrual during the course of the trial. So, oh, sorry. These were exactly we assumed that patients would progress linearly. When I look back at the adaptive design report, we had 4 different profiles of progression that we simulated. And we even simulated some differential benefit over visits. But this was the standard scenario we presented for power and largely looked at was that patients would progress linearly over the course of time. And you can see we've also taken a fraction of standard deviation. There's less variability at change from baseline at 3 months than there is at 12.
Okay, one more question. In the 2D dose specification, there's a question about whether the spacing between the doses is ordinal or an absolute measure. And
Yeah.
so where 0 to 1 is that the same as 1 to 2 and 2 to 3 in the dose strengths.
Yes. So it's interesting. This value on the right, and maybe we should give it a different name. This has nothing to do with the modeling. That's saying, okay, you have 2 dimensionals. You have to tell facts, the order of them for minimally effective or ED90. But the dose response model is triggered by these values. And the NDLM has a variance parameter to it. So because I'm analyzing this You can see there's a distance here in each of these. And so if I spread the dose out farther, the amount that it borrows on tau is standardized to be a 1 unit change. If I make a dose farther away, it smooths less because tau is a 1 unit change, but FACS does adjust by those differences. So in this modeling, when I originally did this, these values dictate that the amount of borrowing is 1 here, 1 here. So it uses tau, but it also, when it goes right to left, it's also 1 in that. I could change those and then tau would be downweighted or upweighted by nearness.
If you had fit a 1D dose response model to your 2D dosing, it would use the effective dose strengths on the right to fit that model.
Yep, sorry, good point. Yep. So I said I want to do 2 dimensions, which means that it uses that for ordering. You could, in your design, you could pick a 1-dimensional model, and then it uses those values that you specified. Thanks, Nick. The scenarios we explored in the design, virtual subject simulation, standard deviation of 0.15. These were at the exact names we gave them at the time. The null was that every dose has a 0.12 decline at 12 months. Equal. A small effect would be the best dose gets a 25% slowing. So that's sort of borderline where they're interested in phase 3 or not, because the difference is 0.03 in that. Then twice a month being good. So better to do twice a month, and there's a dose response model getting to a 50% effect. This one and the medium effect were the ones that largely were looked at the most, I think, in optimizing the design. We looked at a case where once a month, Kilo. So these 2 doses do incredibly well. The other doses don't do much. Both doses are good. And so in this particular scenario, not all that interesting, huge effect, 10 milligrams bi-monthly, U-shaped curves. So maybe giving more drug is bad, but intermediate dosing at the schedules, U-shaped dosing, small effects, only 1 dose works. None, that's the only dose that works. All of them work equally well with different effects, and then a medium effect scenario. So I ran this at about 9:49 yesterday. And so to run 1,000 simulations of this design where it's doing 15 or 16 interim analyses in some of these trials, it took about 5 minutes in FACS to do those 1,000 scenarios in this case. We can look at maybe this BM good scenario for a couple of these. Notice, so the truth is in black. The 10 milligrams bi-monthly, that's the most invasive dosing, is the best. And it has a 50% slowing, 0.06 at 12 months. The 10 milligrams once a month is pretty good. 0.08, that would be a 33% slowing. So these are the 2 best doses. Notice the average number of patients are highest on those doses. The control has 28% of them. The model estimate averages over to be the black one. The frequency of times that the ED90 is picked for these doses. So about 55% of the time it would pick 10 milligrams bi-monthly. 10 milligrams once a month about 21% of the time, and 5 milligrams bi-monthly, which is as good as this dose. These each have a 33% slowing, has a little bit less chance of being picked. But those are the likelihoods, and we make some negative, bad choices. You can see that occasionally. Success stopping in that scenario, we can look at over the interim analyses. So 350 the first time at success, and we can see the timing of success and when they happen. So this trial is about a 65% chance under this scenario of triggering success, and you can see when it happens. Futility stopping almost never happens in that scenario. We looked at the average sample size in that scenario. It's kind of nice, that's averaged over 1,000. We can look at per trial and see what it looks like. Here's a trial where 10 milligrams once a month was the biggest sample size, and it was doing the best. Notice the raw data, it would pick that arm in that scenario. And we can kind of look through and see what happens on them and the fit and the pick to them. You can go through per interim analysis within that. We can look at the null. So if the drug doesn't work, on average, each of the doses gets similar sample sizes, maybe slightly bigger on the 5 milligram monthly because it's the least invasive dose. Success stopping over sample size happens early success 6.9%, late success less than a half. So about 7.5% chance that we trigger go to phase 3 under the null. In that scenario, success to futility in that scenario, futility to success, I think never really happened. Futility to success, we continued the trial. That was the question, just to see how often it happened. It never happened in 1,000 trials. Futility 30% of the time in that scenario. Again, this was done over and over again with these scenarios. We probably started with less, and then we added them as they became more interesting. Within that, all the thresholds were explored, the sample size was explored, the first interim, the timing, to this final design. So adaptive design is not about, dictated from God as to this is the design. You use facts as the sort of mirror to how good is this design, simulated over and over and over again, optimizing the design. Hopefully at the end, this is something where if you remove one part of this, if you change it, it diminishes the whole design. Sorry, I am not Mozart, and nor is this design Mozart's music, but to borrow from the movie. Okay, rather than showing you simulated movies, I will show you a real movie. This is the only trial I know where the sponsor has published every interim analysis during the course of the trial. And I'll show you the publication of that. So this is a picture that was actually looked at. I changed the colors and I changed some things, but largely these figures were looked at by the DSMB and the Statistical Analysis Committee as the trial was running. So the first interim, this is real data. The first interim analysis took place, 197 patients enrolled. And in the middle, you see the estimate. There's not even raw data on there because not a single patient had reached 12 months within that. And these are the estimates of the 12-month decline. Interestingly, by the way, the mean of that alpha parameter in the longitudinal model being 0 and standard deviation 0.05 is why this doesn't sort of jump up. But the relative comparison of the doses within this scenario, it gives you a hint of the data at this time point. The placebo, 10 monthly and 10 bi-monthly have the lowest estimates at this point of that. The placebo is doing pretty well. You can see the exposure. There are 56 or 7 patients on placebo. You can see how many of them only have baseline, how many have 3 months, and how many have 6 months. And there's looks like 9 months. Maybe my coloring is off here. Sometimes we may have had a patient enrolled very early. I don't think anybody's at 12 months yet. Maybe my color is off here. But you can see the exposure of the patients of that. The probability of super superiority within this is this blue line there. The probability of being in the ED90 is this black one. The green are the new randomization probabilities for the arms. Probability to the 5 bi-monthly is going down to essentially 0. In that one, get more 10 bi-monthly, 10 monthly at that time. If this blue line dropped below this red line, it would have hit futility. So the trial went to 250. This is about 2.5 months later. You can see the additional exposure here. Within this, you can see we get now more patients at 9 months. You can see the randomization, the 10 monthly, the 10 bi-monthly, the 2.5 got more patients. Few on 5 at 250. If that's below 5%, it would have triggered futility, and it's hovering at about 18%. And you can see green are the new randomization probabilities. 300 analysis at that time point. Now we start to see data at 12 months. And you can see the raw data are those patients that have passed 12 months within this. Notice at this time point, the placebo is the single best arm in the trial. Had this trial been a typical small phase 2 trial, 300 patients enrolled in this way, this is dead. The probability of super superiority is below the futility for every dose but the 2 10s. This is about 16%. If it was below this value of 5%, trial would have stopped for futility. Again, this was simulated under scenarios to make sure this was unlikely to happen in scenarios you didn't want it to happen. Now at 350, more data reaching 12 months in this scenario. Now you can see the 10s are doing really well. Placebo's going up. The other 3 arms are not doing very well at this time point. Success comes in the picture. If that blue line right there jumped above that, it would say go run phase 3, and it would pick the most likely ED90, which is the 10 bi-monthly. It would pick that dose. That model-based estimate is the best for 10 bi-monthly at 356 patients. It doesn't hit futility. Notice that jumps up to 7.5% at this one. 95 in this scenario, randomizations are green. Randomization says, give me the high doses. I don't really want the low doses at all at this point. 400, 450. Probability of super superiority is kind of in the middle here. 50-50 shot that you've got a 25% reduction in this. It likes the 2. Now it actually likes the 10 monthly better as the ED90, in part because it's a smaller dose. They look very similar, but it's a better dose to give. That's now being favored. So the trial continues on at this point. In each one, you can see the randomization. And I'm going to come back to the randomization. Something funky happened in this trial that I haven't really mentioned yet, but show you the simulation of this. It gets to 700. And again, this probability of super superiority for this dose is 41%. For this dose is 64%. It's not 95. It's not go to phase 3. It's not futile. And it's continuing to give the placebo and largely the 2 high doses, 10 bi-monthly, 10 monthly, doesn't care much about the lower doses. Notice the raw data for those and the model estimated value, which is using more than the raw data because it's using the 3, 6, 9, and 12, 9-month data as well in here. All of these non-purples are going into that modeling. So it reaches the 800 analysis, and it's got 815, and it does not hit success. It's starting to look really good. 68% chance that it's at least 0.03, 25% slowing. Starting to look really positive here in that. Again, the 10s and 10s. And you can see the randomization to those arms and the placebo at this point. Now it over enrolls to 856. So the trial ends up through the different sites and patients through the screening period ends up enrolling 856. But at this point, it's done enrolling. And now it's looking every 3 months in the trial. Again, they want to go to phase 3 if they hit that 95% threshold. And it doesn't. It's 50, 60, 65% is that probability of super superiority. And notice the estimate on placebo is about 0.11 at 12 months. And it's about 0.07 for the 10 bi-monthly. It's the arm it likes the best. 10 monthly second best. Then 5 bi-monthly and so on, but largely it's focusing on the 2 high doses at this point. The other doses would hit futility. This is now the 12-month analysis. Every patient has the opportunity to get to 12 months. Now there are dropouts. These patients will never achieve that. That data is being included in this analysis through the longitudinal modeling of this. And notice now the probability of super superiority is 64%. If that hits 80, it would have told the company, go to phase 3. The sponsor is entirely blinded at this point. They do not know the data. They're hearing at every analysis, keep going, keep going. You don't know the answer yet, keep going. This is publicly disclosed at this point that the trial is keep going. So the sponsor, who's ASI, puts out a press release. Neither early success nor failure for Band 2401. This is the Alzheimer's Forum. Despite an adaptive design to grease its wheels, a phase 2 clinical study of the amyloid antibody Band 2401 demonstrated no clinical benefit. It didn't demonstrate that at 12 months in people, but it didn't trigger success. Sponsors now await the 18-month time point to draw conclusions about the efficacy of the treatment and decide whether to move to phase 3. While the findings come as a disappointment to those hoping for speedy result, they leave open the possibility of success. These people are all blinded to the data. Don Barry's quoted in this. He's blinded to the data. He says, on balance, this is probably good news because Alzheimer's, nothing works, and it didn't stop for futility. But an interesting quote from Paul Azen. who you can tell from the quote, he's sort of negative on adaptive designs. He says the greatest concern about Bayesian adaptive approaches in Alzheimer's disease relates to our cognitive clinical outcome measures. These measures are highly variable and noisy. Adapting on interim, incomplete data risks chasing noise and making erroneous decisions regarding efficacy or futility. I was unblinded and read this, and I wanted to scream, but I wasn't allowed to. The thing was, the design said exactly that. You don't know the answer yet. It could be good. Keep going. And yet the design's criticized because it could trigger too early. And of course, the alternative to this design is probably a small phase 2 with a 6-month endpoint and then make a decision. So it was sort of ironic, I think, that it was criticized for doing exactly what it did. So the final analysis at 18 months came out, 76% probability of hitting 25% slowing. The data was even more promising at 18 months in this trial, and hit that, and it was the 10 bi-monthly dose within that. So ASI was unblinded to the data at this point. The final analysis of that data, this is just showing the same thing. By the way, you can see the timing of this. So it started off in 2014 in February 3rd. This is European ordering of this. And the final readout was in December of 2017. Oh, where's my estimate? Oh, here we go. The final analysis of 18-month data estimated that the 10 milligrams biweekly dose had a 73% ratio to placebo, meaning a 26.4% slowing of disease. Statistically significant, but that was never the criterion in the trial. It was always super superiority, which was 76%. They didn't want statistical significance. It was not a phase 3 trial. It was phase 2 go. But this estimated the 10 milligram biweekly as a 27% slowing. So they ran phase 3. They powered it off of that. They picked the 10 milligram bi-monthly dose. And in 1,700 patients, 1,800 patients, 1-to-1 randomized, not a Bayesian design, frequentist design, MMRM analysis at 18 months. It showed a 27% slowing on the primary analysis and a p-value of 0.00005, showing statistically significant decline on the primary endpoint for that dose that went forward. A different endpoint, by the way, CDR sum of boxes, while phase 2 was ADCOMS. It was given full approval by FDA based on this phase 3 study. It was given accelerated approval based on the phase 2 trial. When the results of the amyloid and the different effect by doses was investigated, this drug was given accelerated approval, as with aducanumab. And then this trial came out, and it's been given full approval of lecanemab within this scenario. All of the results, all of the interim data, you can go through in all its gory detail and see that. You can even see the reports that were created and were looked at by the DSMB have been published in the supplement. The supplement to this paper is awesome. And I don't know another paper that shows you each of the individual interims and what happened during the course of the trial. It's the only one I know about, so it's pretty awesome. Interesting part of the story is here's another paper published on an AbbVie drug. Within this, you'll see my name over there, of an adaptive phase 2 trial in Alzheimer's disease. It actually has a quite similar trial design to this one. it stopped for futility. So it had 3 arms instead of 5, but in adaptive design, response adaptive randomization, it stopped for futility early in the trial. So, it's not that the design creates the success of it. Hopefully it brings about the truth of the arm, which that phase 2 trial did a pretty good job, as evidenced by the phase 3 trial, and this one stopped for futility. So the result of the trial can be different as a function of the drug that you plug into it. All right. Any other questions, Nick?
No, no comment. Awesome success story, but that's it.
Again, I'll highlight the importance of and the ability to go back and simulate that thoroughly, explore the design, show the team movies just like that, where they got to see this doesn't stop for futility, this keeps going. The huge part of that. Now, this trial, by the way, was originally designed with custom code. FACS did not exist at this time. It took, writing custom code, simulating it, debugging it, all of that. Each time we did this, maybe a couple weeks, I'll come back to you with those changes. We'll explore those changes, couple weeks, 6 months to do this. FACS, it took 3 minutes to simulate this particular design. We could have done it faster without mistakes, exploring thresholds. So FACS gives you that mirror to look at the operating characteristics, to optimize the design, look at it so much faster than custom coding and doing this, and the ability, it's very hard to design trials where you have to do that custom coding throughout. And so that's sort of the value of FACS within this scenario. And by the way, a great movie. If you've not seen Amadeus, you should watch that movie. We have multiple quotes that we say around Berry Consultants that are directly from that movie. And this is one of them, as though it was dictated by God. All right. Appreciate it. Thanks everybody for joining.